We'll be breaking down all major concepts covered on the exam.
Right, because we want you to be completely ready for this.
Exactly. I mean, imagine sitting down to a meal, taking a simple sip of water, and your body just forcefully rejects it.
Yeah, it's a terrifying thought.
It really is. The tube connecting your mouth to your stomach has simply, well, stopped working. Today, we are exploring the suffocating reality of dysphagia.
Welcome to this deep dive. If you're a Canadian medical student gearing up for your exams, you are in exactly the right place.
For sure. We are your MCCQE reviewers, and our entire goal is to help you feel completely comfortable with the gastroenterology review process.
And we're taking a vast amount of medical information and really synthesizing it into the high-yield, purely clinical pearls you need to master.
Yeah, and we are building this discussion squarely on incredibly reliable, peer-reviewed StatPearls articles to guide our clinical approach.
Absolutely. But before we jump into the deep end, we do have to give our standard, very important disclaimer.
Right. This deep dive is for medical education purposes only. It is not medical advice, and any clinical decisions must always involve a qualified healthcare provider.
Okay, so let's unpack this. Today's mission is section S04 GASTROENTEROLOGY, specifically the approach to the patient with dysphagia.
Yeah, when someone comes into the clinic and says, I can't swallow, we are basically looking at an internal transport problem.
Right. The esophagus really just has one job: move the food bolus from the pharynx to the stomach and, don't let it come back up.
Exactly. And framing it as a transport problem is highly useful for exam vignettes.
Because when that system breaks down, your diagnostic workup has to figure out if it's a structural or functional failure.
I mean, broadly speaking, either the tube is clamped shut by a neuromuscular failure or the tube is physically blocked by a progressive barricade.
Or the wall of the tube itself is just blown out.
Right. So let's start with that first scenario, the tube clamping shut. We're talking about the neuromuscular bottleneck, otherwise known as achalasia.
Yes, achalasia. It's an esophageal, smooth muscle motility disorder, and it seems to pop up on every single exam, despite being relatively rare.
Yeah, why is that? Why do they love testing it so much?
Well, it's a classic because it tests your understanding of foundational physiology.
Right.
What's fundamentally happening is a failure of the lower esophageal sphincter, the LES, to relax.
And that failure is paired with a complete absence of normal peristalsis in the esophageal body itself, right?
Exactly. So it creates a functional obstruction at the gastroesophageal junction.
Okay, here's where it gets really interesting for the pathophysiology heads out there. Why is it failing to relax? I mean, it's not just a random muscle spasm?
No, not at all. The source material points out that we're looking at a literal degeneration of the myenteric plexus and the vagus nerve fibers.
Wow, okay. So the nerves are actually dying.
Yeah, the physiology here is a delicate balance of opposing forces. You have to think of the lower esophageal sphincter as being under constant, resting, excitatory tone.
So it wants to stay closed by default?
Exactly. For food to pass, it needs a direct signal to relax. That inhibitory signal is normally driven by neurons releasing vasoactive intestinal peptide, or VIP nitric oxide.
Okay. VIP and NO. Got it.
Right. But in achalasia, those specific non-cholinergic, non-adrenergic inhibitory ganglion cells degenerate and disappear.
Meaning the excitatory neurons, like the ones using acetylcholine to trigger contraction, are just left completely unopposed.
Precisely. So the sphincter is aggressively clamped shut.
Man, it's like a bouncer at a club just refusing to let anyone in, and the line outside keeps growing and growing.
That's a great analogy. And because that line of food and liquid keeps growing, the esophagus itself physically dilates to accommodate the backlog.
Right, which leads to that massive chronic dilation.
Yeah, and that stretches the esophageal tissue far beyond its normal capacity, leading to an irreversible loss of peristalsis.
Wow, so the muscle just gives up, which gives us a massive clue for the exam regarding clinical presentation, right?
Yes, exactly. A patient with achalasia typically presents with dysphagia to solids and liquids at the exact same time.
At the exact same time. That's key. The StatPearls text notes this happens in 70 to 97% of patients right at presentation.
Right, because the sphincter is clamped so tight, gravity alone isn't even enough to pull a liquid like water through into the stomach.
So if the dysphagia is to both solids and liquids simultaneously from the onset, you must think of a functional motility issue.
Always. And these patients will also report regurgitating completely undigested food, experiencing chest pain, and rapid weight loss.
I mean, they simply cannot get enough calories past that clamped sphincter. The sources even mention a bullfrog neck appearance in severe
Oh
cases.
yeah, that is a striking physical exam finding.
What causes that? Just the sheer volume of backed up food.
Exactly. The cervical portion of the esophagus becomes so dilated with retained food and fluid that it physically bulges outward in the neck.
That's wild. And it can even lead to tracheal compression and audible stridor,
Yes,
right?
Ken, yeah. You also want to keep the Eckert symptom score in mind to evaluate disease severity.
Okay, the Eckert score, what does that cover?
It grades 4 things: weight loss, chest pain, dysphagia, and regurgitation. It grades them from 0 to 3 to help clinicians track if treatments are actually working over time.
Okay, speaking of treatments, I have a question. If the muscle is clamped shut and permanently scarred from nerve degeneration, why do we sometimes inject Botox into it?
Ah, right. So botulinum toxin is a potent neurotoxin that directly blocks the presynaptic release of acetylcholine.
Right, and acetylcholine is what's causing the contraction.
Exactly. Remember, those excitatory neurons are working unopposed because the inhibitory ones are dead. So by injecting Botox directly into the LES during an endoscopy, we paralyze those overactive excitatory neurons.
Oh, I see. It basically forces the sphincter to relax and open.
Right. But the nerve endings eventually sprout new connections, right?
Yeah, so it can't be a permanent fix.
No, the effect only lasts about 6 to 12 months. It's strictly considered a temporary bridge therapy or, a palliative option for frail patients.
That makes sense. Now, definitively diagnosing this requires a very specific sequence of tests.
Yes, you can't just guess based on symptoms.
Right. I know the best initial test is a barium swallow. You have the patient drink contrast, and under fluoroscopy, you look for that classic bird's beak appearance.
Which is that smooth, symmetric tapering of the lower esophagus with massive dilation above it.
Exactly. But we can't just stop at the barium swallow, right?
No, an upper endoscopy in EGD is absolutely required in all suspected cases of achalasia.
To visually inspect the gastroesophageal junction.
Exactly. You have to rule out pseudoachalasia.
Meaning you have to prove there isn't a tumor hiding at the GE junction that's just mimicking the symptoms.
Right. If the endoscope meets firm, rigid resistance when trying to push through the sphincter, alarm bells for a malignant tumor should be ringing.
Okay, especially in older patients who present with a really short duration of symptoms and rapid weight loss.
Yes. True achalasia tends to be a bit more insidious.
Got it. Now, assuming the EGD is clear, we still need the gold standard test to confirm the functional motility failure, right?
Yes, esophageal manometry. And the sources go deep into high-resolution manometry, using the Chicago criteria.
Right, which classifies achalasia into 3 distinct types. Why is that classification so critical?
Because it dictates prognosis. Type 1 is classic achalasia with no pressurization in the esophageal body. The muscle is just dead.
Okay, and type 2?
Type 2 has panesophageal pressurization. The entire esophagus is squeezing simultaneously, trying its hardest to overcome the clamped sphincter.
And then type 3 involves what? Spastic and premature contractions?
Exactly. It's very chaotic.
Is it true that type 2 actually has the best response to treatment?
It does, yeah. Because the esophageal body still has some coordinated muscle tone left, opening the sphincter yields excellent functional results.
And to open that sphincter long term, we're talking about pneumatic dilation, literally blowing up a balloon inside the LES to tear the muscle fibers.
Or surgical intervention, like the laparoscopic Heller myotomy, where a surgeon cuts the constricting muscle fibers.
But wait, if we just cut the muscle and destroy the sphincter, aren't we just opening the floodgates for stomach acid?
Yes. That is a crucial surgical trap for the exam. If you completely destroy the barrier, you basically trade achalasia for a severe GERD.
Oh, wow. So how do surgeons prevent these patients from getting massive acid reflux?
They pair the myotomy with a fundoplication. They wrap the top portion of the stomach, the fundus, around the esophagus to recreate a valve.
Oh, I see. But the trap for the exam is that it must be a partial fundoplication, right? Like a door or toupee procedure.
Exactly. It cannot be a complete 360-degree Nissen fundoplication.
Because if you do a complete tight wrap on an esophagus that has no peristalsis, you just cause severe dysphagia all over again.
Right. You've essentially recreated the exact problem you just fixed. You have to leave the door a little bit open with a partial wrap.
Okay, so we just established that achalasia causes simultaneous dysphagia to solids and liquids because of a functional nerve failure.
Correct.
But what does it mean when a patient comes in and says, a few months ago, meat got stuck, then bread, and now I can't even swallow liquids?
Right. So progressive dysphagia, first solids, then liquids.
Yeah.
The physiology has changed entirely there. When you see progressive dysphagia, the tube is no longer functionally clamped.
It's being physically blocked.
Exactly.
Mm.
The lumen is slowly being closed off by a physical, growing mass. On the MCCQE, progressive dysphagia paired with weight loss points immediately to esophageal cancer.
Okay, and we are dealing with a tale of two entirely distinct pathologies here, right? Squamous cell carcinoma and adenocarcinoma.
Yes, they have different risk factors, different locations, and totally different epidemiological trends in North America.
Let's start with squamous cell carcinoma, or SCC.
SCC typically occurs in the upper and middle thirds of the esophagus.
And globally, it is the most common type, right? Dominating that esophageal cancer belt from parts of Iran into China.
Right. But in Western countries like the US and Canada, SCC incidence has actually been steadily decreasing.
Because we refrigerate our food now instead of curing meats with nitrosamines.
That dietary shift plays a massive role. For SCC, the primary risk factors are smoking, excessive alcohol consumption, and diets low in fruits and veggies.
Oh, and drinking extremely hot beverages that chronically burn the mucosa over decades is another fascinating risk factor.
It is. And bringing it back to our previous topic, achalasia is also a significant risk factor for SCC.
Wait, how does a clamped sphincter lead to cancer in the upper esophagus?
It comes down to chronic stasis. The food and liquids sitting in that dilated esophagus slowly ferment and rot.
Ugh, that sounds awful. So it just creates a highly toxic environment.
Exactly. It creates an inflammatory environment that constantly damages the squamous cells lining the middle and upper esophagus, eventually driving malignant transformation.
Okay, contrast that with adenocarcinoma, the type that is rapidly rising in North America.
Right. Adenocarcinoma almost exclusively affects the distal esophagus and the gastroesophageal junction.
And the pathophysiology there is a highly predictable cascade, right? It starts with chronic GERD.
Yes. The lower esophagus is repeatedly bathed in harsh stomach acid and bile. The normal squamous epithelium simply can't handle it.
So it adapts. It undergoes metaplasia, changing into a more acid-resistant intestinal-type columnar epithelium.
And that cellular change is what we call Barrett's esophagus.
Right. Barrett's esophagus is the necessary precursor.
Exactly. Over time, that metaplastic tissue accumulates genetic mutations, progressing from low-grade to high-grade dysplasia and finally to invasive adenocarcinoma.
So the risk factors map perfectly to that. Chronic GERD, a high BMI which mechanically forces acid upward, and smoking.
Notice alcohol is not a primary risk factor for adenocarcinoma. That's a great nuance to keep in mind for the exam.
Definitely. Clinically, both types present with that progressive dysphagia, massive weight loss, and often iron deficiency anemia from the tumor slowly bleeding.
You also really want to watch out for a specific anatomical exam clue in the clinical vignette: hoarseness.
Oh, right. Because if the patient has a suddenly hoarse voice, the tumor has likely grown outside the esophagus and invaded the recurrent laryngeal nerve.
Exactly. That tells you the disease is locally advanced.
For diagnosis, just like with achalasia, you start with an upper endoscopy.
But this time, the goal is to take multiple biopsies for histological confirmation.
Great. And once the pathologist confirms cancer, the entire focus shifts to clinical staging, which heavily relies on endoscopic ultrasound, or EUS.
Right.
But why is EUS so critical here? Why not just use a standard CT scan?
Well, a standard CT scan is great for the big picture, but it cannot differentiate the microscopic layers of the esophageal wall.
Oh, so the EUS puts a high-frequency probe right up against the tumor from the inside.
Exactly. It tells you exactly how deep the tumor has penetrated. Is it just in the mucosa? Has it breached the muscle? Or is it invading surrounding organs?
And that depth, the T-stage, dictates your entire treatment algorithm.
Yes. And you'll pair the EUS with a whole-body PT-CT scan to hunt for distant metastases.
Okay, let's explore a clinical scenario. We have a patient who needs a massive surgery, an esophagectomy, to remove a large tumor. They've lost 50 pounds and can't swallow anything. My instinct is to say, let's put a percutaneous feeding tube directly into their stomach to bulk them up with nutrition before surgery.
And that is a catastrophic management mistake.
Right. Why is that such a lethal surgical trap on the exam?
If you place a gastrostomy tube, a G tube, you punch a hole in the stomach and create dense scar tissue anchoring it to the abdominal wall.
Right.
When the thoracic surgeon goes in to perform the esophagectomy, They have to remove the diseased esophagus.
And to reconstruct the GI tract, they need to mobilize the stomach, pull it all the way up into the chest, and sew it to the healthy esophagus.
Exactly. The stomach becomes the pull-up conduit, and if you've damaged it with a G-tube, compromised its blood supply, or tethered it with scar tissue.
The surgeon can't stretch it up into the chest.
Right. You have ruined their primary option for reconstruction.
Wow. So if they desperately need a feeding tube prior to surgery, you must place a jejunostomy tube down in the small intestine.
Yes, you must leave the stomach completely pristine.
That is such a high-yield pearl. So what does the standard of care actually look like for treating these patients?
If caught incredibly early, you might be able to perform an endoscopic mucosal resection, shaving the cancer off from the inside.
But for most symptomatic patients, they already have localized disease.
Right. The gold standard there is neoadjuvant chemoradiation, followed by esophagectomy.
The landmark CROSS trial proved this, right? Giving chemo and radiation before surgery.
Yes, the CROSS trial fundamentally changed management. Giving the therapy up front shrinks the tumor, making it easier to resect, and wipes out circulating micrometastases.
Which drastically improves long-term survival. And when they finally do the surgery, the guidelines say they must resect at least 15 lymph nodes. Why 15?
Because the lymphatic drainage of the esophagus is incredibly rich and longitudinal. Cancer cells can travel far up into the neck or deep into the abdomen very quickly.
So harvesting at least 15 ensures you've accurately staged the patient.
Exactly. And we should mention advanced disease. If a patient have metastatic adenocarcinoma, you must test the tumor biopsy for HER2 overexpression.
Oh, right. If it's HER2 positive, adding trastuzumab to their chemo provides a significant survival benefit.
Absolutely.
Okay, so we've seen what happens when the tube is functionally clamped shut and when a tumor physically blocks the path.
Right.
But those high intraluminal pressures from a closed sphincter or a blockage don't just disappear, they push relentlessly against the esophageal wall.
Which leads us to our third scenario.
Yeah.
Esophageal diverticula. What happens when the wall itself just gives way?
Yeah, let's talk about that. Diverticula are basically outpouchings of the esophageal wall.
Right. We classify them anatomically and pathophysiologically. The most critical distinction is between true and false diverticula.
A true diverticulum contains all 4 layers of the normal wall: mucosa, submucosa, muscularis, and adventitia.
And those are typically formed by traction.
Meaning something outside the esophagus is literally pulling on the wall. Right.
Exactly. We see this most commonly in the mid-esophagus. If a patient has severe mediastinal inflammation like from histoplasmosis, the inflamed lymph nodes adhere to the esophagus.
And as they heal and scar, they physically pull all 4 layers outward.
Right. But the more commonly tested diverticula are the false ones.
Formed by pulsion, they contain only the inner 2 layers, the mucosa and submucosa.
Right. Abnormally high intraluminal pressure forces the delicate inner lining to herniate out through a weakness in the muscle layer.
It is exactly like an inner tube bulging out through a crack in a bicycle tire.
That's a perfect way to visualize it. And this happens at the extreme ends of the esophagus where pressures are highest.
Like at the very top in the hypopharynx, where you get a Zenker's diverticulum.
Yes. It pushes through a natural area of muscular weakness called Killian's triangle.
Right, which sits between the fibers of the inferior pharyngeal constrictor and the cricopharyngeus muscle. Zenker's is incredibly high yield for the exam.
It usually shows up in elderly patients, and the symptoms are pretty unique.
Because the pouch sits so high up in the neck, food and pills collect in the diverticulum before they ever reach the stomach.
So patients complain of regurgitating completely intact, undigested food hours or days after eating.
And because it ferments in that pouch, they develop severe halitosis, right?
Yeah.
Really bad breath.
Yes. And the most dangerous complication is that the retained contents can spill over into the airway while they sleep.
Causing recurrent aspiration pneumonia.
Exactly.
Yeah.
You also mentioned they happen at the bottom of the esophagus.
Yeah, an epiphrenic diverticulum.
Yeah.
Usually driven by the intense pressures of an underlying motility disorder like achalasia.
Right.
Okay, I want to run another clinical scenario by you, representing a very real danger.
Sure.
A 75-year-old man comes into the ED with terrible bad breath, regurgitating whole pieces of food, and severe dysphagia. My instinct is to grab an endoscope, go down his throat, and see what's stuck. Why is that a lethal mistake?
Because if he has a Zenker's diverticulum, that pouch sits directly in the anatomical pathway of your scope. As you push the scope down, the tip will naturally follow the path of least resistance right into the diverticulum instead of the true esophageal lumen.
And because it's a false diverticulum,
It's only made of millimeter-thin mucosa. It has no tough muscle layer to protect it.
Oh man, so your endoscope will just punch right through that thin wall.
Exactly, causing a catastrophic esophageal perforation. You'll spill oral bacteria directly into the neck and mediastinum, leading to rapidly fatal mediastinitis.
That is terrifying. So what is the safest initial diagnostic test if you suspect a Zenker's?
A barium esophagogram. You watch under continuous fluoroscopy as they swallow liquid contrast.
You physically see the pouch fill up with white barium, confirming the diagnosis safely.
Right. It maps the anatomy so a specialist knows exactly what they are dealing with before ever considering an endoscopy.
Okay, once we have the diagnosis, what's the management?
If it's small and asymptomatic, observation is fine. But if they are aspirating or losing weight, you need to intervene structurally.
The goal is to divide the common wall between the diverticulum and the true esophagus, turning two tubes into one.
Crucially, you must simultaneously perform a cricopharyngeal myotomy.
Right, cutting the muscle to relieve the high pressure that caused the blowout in the first place.
Yes, and they can do that entirely endoscopically now with the Dolman procedure.
Endoscopic myotomy is preferred because it's minimally invasive, but there is an anatomical catch, right?
Yeah. Using a rigid endoscope requires significant neck extension. If your patient is elderly and has severe cervical stenosis or poor jaw mobility, they won't tolerate the positioning.
So in those cases, you have to pivot to an open surgical approach through the side of the neck.
Exactly. The clinical nuances there, when to scope, evaluating neck mobility, are what separates a good test taker from a great one.
We have covered an immense amount of ground today. Let's do a quick, high-yield recap of the diagnostic triad for our listeners.
Sounds good.
If a patient presents with dysphagia to solids and liquids at the exact same time, you are thinking about a functional motility issue, specifically achalasia. The tube is neuromuscularly clamped shut.
Right.
If a patient presents with progressive dysphagia trouble with solid food first, then liquids paired with massive weight loss, you are thinking about a mechanical block. That's esophageal cancer.
Exactly.
And if a patient presents with severe halitosis and regurgitating impact, completely undigested food, you are thinking about an anatomic blowout, an esophageal diverticulum, most likely a Zenker's in the neck.
Keeping that triad clear in your mind provides a phenomenal framework. And remember the clinical traps: no gastric tubes for esophageal cancer patients, and no blind endoscopies for suspected Zenker's.
As we wrap up, I want to leave you with a lingering, provocative mystery drawn straight from the StatPearls text.
Oh, this is fascinating.
We know the exact mechanism of primary achalasia. It's caused by the degeneration of the inhibitory neurons in the mind-heric plexus. But why?
Right, the root origin is still completely unknown.
Emerging theories suggest that maybe a simple, mundane childhood viral infection sets off a slow-burning autoimmune phenomenon in a genetically susceptible host.
It's wild to think about.
Could a random forgettable virus you caught when you were 7 years old be quietly, methodically rewriting your esophageal nervous system decades before you ever feel your first swallow get stuck?
It's a deeply humbling reminder. Even when we can perfectly map the pathophysiology and cure the symptoms, the true origin story often remains a complete ghost.
It really does. Thank you for joining us on this deep dive into esophageal pathology. You are now significantly better prepared to tackle the gastroenterology section of your MCCQE exam. Keep studying hard, trust your preparation, and we will see you on the next one.